Hi, everybody. This is Drew Cutler from Heologics, and I'm here today with my colleague, Dr. John Taenzler. John joined Heologics last May as a Senior Vice President, and I must say that he brings a wealth of knowledge and experience to our company, both as far as market research in general and specifically with regards to oncology. So I'm absolutely delighted to have John on board, and I've already found he's a font of knowledge that I can turn to whenever I need to do so. And today happens to be one of those occasions. For our podcast today, I will be talking with John and asking him some questions about an area that I would like to have more knowledge about than I currently do, specifically multidisciplinary teams, or MDTs, in the oncology space. So, John, good morning, and tell us, please, a little bit about yourself and your research background.
Hey, good morning, Drew. I have a doctorate in experimental developmental neuropsychology from Clark University, and when I was finishing my graduate training and doing some postdoc information, I informed my wife that I would like to get a second PhD in biology. To which he told me, I think you need to get a job. So that's how I ended up in market research, kind of pursuing my, medical interests, but yet the creativity of market research always kind of really appealed to me. When it comes to oncology, I've always had an interest in oncology, but it really picked up kind of in the early 2000s when molecular diagnostics started being involved in the treatment of oncology, and that's what really got me going, and I've been doing oncology projects ever since.
Very good. Well, the world is better for you having made that choice. And let's focus in, John, on multidisciplinary teams, or MDTs, within the oncology space. Tell the listener, please, briefly, what exactly is a multidisciplinary team?
So, multidisciplinary team is the attempt by healthcare providers to work together with their colleagues across specialties to help with the diagnostics, the treatment, the follow-up, and prognostics of cancer patients. Now, the term multidisciplinary team really first started appearing in the literature in the mid-'70s. I think 1975 is when it first started coming around in the literature. But it took until the late 90s before many hospitals started integrating multidisciplinary teams, or MDTs, in their system. Now, in the U.S., multidisciplinary teams can exist across different treatments and different conditions. In the U.S., multidisciplinary teams are typically known as tumor boards.
And if I understand correctly, there are multidisciplinary teams in other areas of medical care, including mental health. Is that correct?
That's correct. I mean, multidisciplinary teams, MDTs, are best when you have a complex, multifaceted condition that requires expertise from more than one particular specialist.
And John, tell us a little bit about how you became knowledgeable about MDTs.
Well, I began hearing about MDTs probably in the early 2000s as I was doing work with oncologists, particularly in dedicated cancer centers. They seem to have developed quicker. And as I was talking with oncologists and oncology surgeons and oncology radiologists, I began to notice they began talking about meeting together as these multidisciplinary teams to discuss their process and the procedures that they undertook for any given patient.
And just within the United States, John, which medical institutions have MDTs and which do not?
Well, currently right now, all dedicated cancer centers have MDTs. The majority, if not all, academic hospitals have tumor boards. Now, for the smaller community hospitals, it really depends on the size of the hospital, their location. MDTs tend to be located in urban areas where there's large populations and large hospital systems. But there are a number of smaller community hospitals and community-based oncologists who will participate with on the tumor boards with the hospital that they're affiliated with. So this has occurred particularly over the last, I would say, decade, that the rank and file oncologist who's working out of an office has the opportunity to participate in a tumor board and gain that shared knowledge.
Mm-hmm. And besides the rank and file oncologist, who else will sit on the tumor board? What other professionals will also be part of the MDT?
Well, it really depends on the type of cancer that you're talking about, but oftentimes the oncologist, or in the case of bloodborne malignancies, you'll have the hematologist oncologist available. You almost always have the pathologist is involved. You also will have the radiologist in terms of not only helping to interpret the imaging that is conducted, but potential also to apply radiation in the terms of radiation oncologist. You oftentimes, particularly for solid tumors, you'll have a surgeon of some sort. There are dedicated oncology surgeons, but most hospitals will use, thoracic surgeons, neurosurgeons, and the like to participate to that extent. You will also have nursing, which is often involved in educating the patient. And as we know, oftentimes we'll get more information from the patient than perhaps even the oncologist will. So they have a deeper understanding of the patient and their limitations and barriers to treatment. But you'll also have social services involved in case the patient needs travel back and forth to the hospital, needs any sort of long-term care post-surgically or post-treatment. So it's a whole host of people who get involved in the tumor boards nowadays.
Quite a few people are involved. Now, does it vary by the size of the institution? So, for example, at a larger medical institution, are the tumor boards generally going to be larger or no?
Not necessarily. Because they have limited time to discuss any one patient type, they try to be as inclusive as possible. But the pathologist, radiologist, oncologist, and or surgeons, they're almost always participated in this along with nursing and social services. Now, the need for subspecialties like pulmonology for lung cancer or interventional radiologists for doing very fine biopsies, they may be called in depending on the type of cancer and the initial deliberating issues with the tumor board.
Very good. Let's talk a little bit, John, about how MDT helps in terms of the care that the patients receive. Why are MDTs an important part of the patient's care these days? How do they have an impact on the treatment that these oncology patients receive?
They have a wide host of influences. Now, let me back up just a little bit. The process in which the MDT meets, they meet typically on a regular basis, weekly, biweekly, or sometimes monthly basis, to review the cases that they have. Now, when a patient case is brought before the tumor board, it's brought at different times along the patient's journey, their cancer treatments. So some tumor boards will only discuss complex cases. So if it tends to be later stage cancers or cancers that are in a risky location, or the patient has particular comorbidities that are difficult to manage, those patients will almost always be brought before the tumor board. What I've found is some of the larger institutions have implemented that all patients be presented to the tumor board, even if it's just kind of acknowledging that the patient is pretty standard and the treatment is pretty obvious. Still bring them before. But the initial steps that the tumor board will make has to do with diagnostics. The reading of initial images, some of the initial tissue samples that they collect in order to confirm a diagnosis is particularly important. And there's been a number of studies that shown that diagnostics is more accurate when presented before a tumor board as opposed to a single specialty making the diagnostics themselves. Now, the second area where they help when it comes to diagnostics is when it comes to this molecular testing that I mentioned earlier. As the science has progressed and researchers have begun to identify that each cancer has its own personality, so to say, in that there are certain chemical drivers and genetic mutations which allow certain cancers to grow, the tumor boards will discuss these potential markers as it not only helps guide the treatment that they will take, but it also guides the treatment sequence and gives the team indication as to the patient's ultimate prognosis at the end. So from the time the patient is initially diagnosed all the way potentially through recurrence and prognosis is brought up in the tumor board.
And, John, it sounds like these meetings, then, that the tumor boards have would be in person, although these days with the pandemic, are they ever done virtually, over Zoom, for example?
Historically, they've always been done in person, but over as you mentioned, with COVID-19 pandemic happening, televisits or telemedicine conferences have been conducted. And actually, what we're finding is that some institutions are leaning more towards the telemedicine aspect of it because it's simpler for doctors to be able to attend, as well as the presentation of materials can be better automated and presented to the team as a whole.
And do they typically discuss multiple patients at one meeting, or how many patients are typically part of the discussion at a single session?
They typically meet for a couple hours, the tumor boards do, although it's highly variable. Doctors have told us they typically have between 10 and 15 minutes to discuss any one patient type. So they try to get as many patients discussed as possible during the time that they're collaborating, but they don't have a tremendous amount of time to discuss any one patient.
And with all the different players that you mentioned who are part of these MDT sessions, John, I imagine some politics inevitably enter into the picture. I'd like to get a sense of what the politics are of the MDT. Perhaps to kind of lead us into that, you can outline some of the key decisions that the MDTs are making collectively. What are they actually deciding on? And then let's get into the politics and how these decisions are arrived at.
Okay. Excellent. So there are politics in the MDTs, and the politics we found arise when the team is faced with two equally potentially beneficial or risky treatment approaches in terms of which way to go. It's things like, to what extent should we resect the tumor? Should it be a full resection, a partial resection, or a minimally invasive procedure for treatment? I mean, is there a need for pre-treatment before surgery or neoadjuvant treatment? And then what is the form of that neoadjuvant treatment? Is it going to be radiation? Is it going to be chemotherapy? Or is it going to be ablation, potentially by an interventional radiologist? So there are a number of areas that tend to cause politics in these situations. Of course, each doctor is an expertise in their own lane, and rightly so, feel that they have the skill and knowledge to successfully treat patients. It's when you have two of these doctors that both think that their approach is equally beneficial to the patient is when these politics tend to arise.
And then who gets the final say if there are disagreements between the members of the MDT?
That is extremely variable. I know we'll talk a little bit about MDTs outside the U.S., but what we found is, at least within the U.S., there tends to be a more collaborative situation among members of the MDT, where the doctors who present the patient to the MDT will listen and take advice from their colleagues In other areas, the doctor who presents the patient to the MDT is looking to do nothing more than to validate the approach that they think is best. So they're kind of taken in, it's like, well, I want to do A, B, and C, and unless someone in the MDT can come up with a valid reason for not doing that approach, ABC is usually what's done.
I see. So ultimately, how long does the decision process take? You mentioned it's 10 to 15 minutes per patient. Are decisions always arrived at in that kind of time frame?
Almost always, unless there's insufficient data. In the case where I'd mentioned in terms of diagnostics, once they've done the initial biopsy of the tissue, the cytology and the morphology, they've used the imaging. They have a pretty good idea of what the tumor is and what stage it is. But there are certain tumor types, particularly in the lung, in the colon, and in the brain, that the team really needs some of this molecular data in order to make a final decision. So if a patient is presented to the tumor board before this information is presented, the tumor board may make the decision at that point, well, we need these findings from the molecular data. So they will help guide the pathologist in conducting those additional assays so that they will have the data in which to make informed decisions.
So once all is said and done, John, and the team has arrived at a decision, what happens next?
It typically falls into the purview of whatever decision is made. So, for example, if it is determined that the patient is not eligible for surgery or resection, the care will fall into the lap of the treating oncologist. If, however, the team decides that resection or some sort of partial or full resection is necessary, then the surgeon basically takes care of that patient from that point forward, follows that patient through recovery, and then the patient is turned over to the medical oncologist.
As you alluded to, let's talk about how things look outside of the United States. Where do MDTs exist ex-U.S., John?
Outside the U.S., they exist in almost all developed medical countries. So Europe, Japan, China, Australia, South Korea, and to some extent in Brazil, although Brazil is just coming up to speed. But they kind of exist all over the place, and their growth and influence is continuing.
And are they modeling their MDTs after ours, or are they radically different from our model? How do they compare?
They're very similar, keeping in mind that even our MDTs are designed after best practices. So everybody's kind of following the same pattern in terms of their structure.
Where do you see MDTs in, say, 5 or 10 years? How are they going to evolve from where they are now? Or do you feel they'll be basically operating the same way they do right now, John?
I think they're going to be operating functionally the same. I believe they're going to be starting to use new tools. The use of artificial intelligence has really started to make an impact in cancer and cancer diagnostics. Keeping in mind, there is so much information about oncology, and it's a field that is exploding in growth. A couple months ago, I was doing an interview with an oncologist, and I asked the oncologist, how do you keep up with all the literature that's published about, the cancer types that you're looking? And he informed me that it's true that it's almost difficult to keep up with, everything being published and everything being studied. And he cited that there were, close to 1,400 cancer articles published in the past year when he talked, which, as you can imagine, is very difficult for, any human being to keep up with. So some of these companies are turning to artificial intelligence to, not only analyze all this literature, but also to look retrospectively at the outcomes of former tumor boards so that they can project and look at prognostics based on what they've actually done in the past as opposed to, theoretical constructs or guidelines that are developed by larger organizations.
Very good. John, before we close this discussion, is there anything else about MDTs that you feel we've left out? Any salient points about these boards that you feel we should also discuss?
MDTs are a vital part of cancer treatments. We're learning more and more that there's no such thing as just a single cancer, that every tumor has its own personality, its own drivers, and its own receptivity or resistance to different treatments. And it's only through bringing these big brains together and working collaboratively are we best able to treat these patients and, to guarantee them, minimally invasive procedures, which won't impact the rest of their lives, treatments that are more likely to be highly successful, but yet minimize the risk and side effects that the patients may have, and overall, helping with the long-term care provided by nursing and social services to help that patient's quality of life continue to stay high. So, I look forward to, the continuing growth of MDTs in the cancer centers that we do research in, and look forward to seeing what tools they're going to be using next to help their process.
Well, it sounds like in the end the patients are really benefiting from these MDTs, and from the information you gave about artificial intelligence, it sounds like things can only get better in the future for the patients. Well, John, this has been very interesting, and I hope for you, the listener, this has been helpful and informative. John, do you want to share your contact information in case the listener would like to follow up with you with any questions that they might have?
Absolutely. I can be reached by email at John Taenzler, that's JOHN TAENZLER @healogics.com, or you can also call my cell at 215-726-2708. Very
good. And if you'd like to reach me, I'm at Drew Cutler, that's DREW.CUTLER @healogics.com. Again, HEALOGIX.com. Or, as you can hear the phone ringing, you can call me at 610-246-0961. Thank you very much for listening to our podcast today, and we look forward to hearing from you soon. Bye-bye now.